excessive straining, especially in which cases patients having BPH or patient having obstructive uropathy because of stricture. Any cause of obstructive uropathy, like strictures, ascites, pregnancy, pseudomyxoma peritonite, heavy weight lifting. So all these are the risk factors for hernia. Question is asked, what is the most common type of hernia in both males and females? It is indirect inguinal, and femoral hernia is more common in females. So 2 questions. Most common hernia in both males and females. And it is indirect inguinal. It's indirect inguinal hernia. Second statement, femoral hernia is more common in females. This is more common in females. These are the 2 frequently asked questions. Now if you see the simple diagram, what you can make out that this is the pubic tubercle. This is pubic tubercle. Here you can make out that this is the sac of femoral hernia, and this is the sac of indirect inguinal hernia. Now what is this? This is the neck of sac. So if you see the neck of sac in relation to pubic tubercle, it is located above and medial in inguinal hernia, and it is located below and lateral in femoral hernia. One relation. Second, you can see that this is vein, this is artery, this is nerve. Femoral vein, artery, nerve. So if you see the relation of femoral vein, artery, nerve with femoral hernia, this is van from medial to lateral. So 2 questions. First, neck of sac in inguinal hernia is located above and medial to pubic tubercle, and in femoral hernia it is located below and lateral to pubic tubercle. Second question is asked, what is the difference between indirect inguinal hernia and direct inguinal hernia? Now see the basic difference. If this is the abdomen, there is deep ring, there is superficial ring. Deep ring is the defecting fascia transversalis, superficial ring is defecting external oblique aponeurosis, and then there is triangle of Hazelbach. Now in indirect inguinal hernia, this is the cord, this is the testis. The sac comes indirectly, first from deep ring, then traverses inguinal canal, comes out via superficial ring. Indirect inguinal hernia, sac is coming directly from posterior abdominal wall via triangle of Hazelbach. So question is asked, what are the boundaries of triangle of Hazelbach? So here you can make out that this is what? Triangle of Hazelbach. So this is triangle of Hazelbach. Here, medially there is rectus abdominis. Medially there is lateral border of rectus abdominis. Laterally there is inferior epigastric artery. And inferiorly there is a ligament. Which one? There is inguinal ligament. So these are the boundaries. Now the question is asked, what is the relation of sac? See this diagram? What is the relation of sac with cord? So if you see here, the relation of sac with cord in indirect inguinal hernia is anterolateral, and if you see the sac here and cord and testis here, this is posterior. So first question, in indirect inguinal hernia, sac is anterolateral to the cord, and in direct inguinal hernia, sac is posterior to the cord. After that, questions are asked that what is the difference between irreducible hernia, incarcerated hernia, obstructed and strangulated hernia? See the difference. If this is the sac, and in the sac, this is the content. Now what is the problem? Sometimes there is formation of adhesions between the sac and content, and then hernia cannot be reduced. This is known as irreducible. So what is irreducible hernia? When hernia cannot be reduced because of presence of adhesions between sac and content. Second, there is incarcerated hernia. What's the problem in incarcerated hernia? See, this is the sac and this is the content. In the content, what? There is fecal matter. So in this bowel, there is presence of fecal matter, and because of presence of fecal matter, the content cannot be reduced. So hernia cannot be reduced because of presence of fecal matter in the content. It is incarcerated. Third is obstructed hernia. Now see what is obstructed hernia? This is the content. Sometimes this neck is very tight, so constricting agent is the neck. Because of this, what happens? There is compression of the bowel leading to intestinal obstruction with preserved blood supply. So intestinal obstruction with preserved blood supply is known as obstructed hernia. And if there is intestinal obstruction with impaired blood supply, that is strangulated hernia. So one picture is clear that what? In strangulated hernia, what is the constricting agent? So the constricting agent is neck. Neck is the constricting agent. First question. Second, what is the content generally? Since it is strangulated, content is generally small intestine followed by omentum. And whenever we are performing herniotomy, we have to give incision over the most prominent part of swelling. So during surgery, this precaution is being taken. During surgery, incision should be given at the most prominent part of the swelling. Second, whenever we are opening the sac, yes, first we are going to open the fundus so that whatever the organisms are there, it should be sucked out. These are the questions in relation to strangulated hernia. After that, some patients are having omentocele and some patients are having enterocele. What's the difference? Omentocele, so obviously content is omentum. Enterocele, so obviously content is small intestine. So here, omentum is the content, and here is the small intestine. Whenever we are trying to reduce the swelling in omentum, the first part is easy to reduce, last part is difficult. So here, first part, it is easy to reduce. Last part, it's difficult. Last part is difficult to reduce, and content is dewy. The content is dewy. Here in enterocele, first part, it's difficult to reduce. but last part reduces easily with gurgling sound. Last part reduces easily with gurgling sound. So these are the differences between omentocele and enterocele. It means whenever we are performing the clinical examination, we can make the diagnosis in majority of cases. So diagnosis of hernia is purely clinical. But the only thing is that the swelling should be visible. In certain cases, in hernia, swelling is not visible. In those cases, what we need radiological investigations like internal hernia and spanglial hernia. So one very important statement: diagnosis of hernia is purely clinical. It's purely clinical. What are the exceptions? First, internal hernia. First is internal hernia, and second is spigelian hernia. Internal hernia and spigelian hernia. In these two cases, the diagnosis is confirmed by either ultrasound or by CT. In management of hernia, there are three terms which are asked. One is herniotomy, second is herniorrhaphy, and third is hernioplasty. What we do in herniotomy, we isolate the sac from heart, we open the sac at fundus, reduce the contents back into peritoneal cavity, apply bursting suture, and excise the redundant sac. This is herniotomy. What is herniorrhaphy? In herniorrhaphy, we perform herniotomy plus inguinal floor strengthening with sutures. Inguinal floor strengthening with sutures. And what is hernioplasty? In hernioplasty, we perform herniotomy plus is the herniotomy plus inguinal floor strengthening with mesh. Inguinal floor strengthening with mesh. Now one basic thing is there. In hernia surgery, what we have to perform first, we have to perform the herniotomy. After that, the strengthening can be done only with the sutures, that is known as primary tissue repair. It can be performed with the mesh, that is known as anterior tension-free repair, or we can go for laparoscopic repair. So what are the hernia repairs? First is primary tissue repair. Primary tissue repair. In primary tissue repair, two questions are asked. First about Bassini. Bassini repair. This is known as triple layer repair. Triple layer repair. Now why it is known as triple layer repair? Because here internal oblique plus transversus abdominis plus fascia transversalis is suture to shelving edge of inguinal ligament. Is suture to shelving edge of inguinal ligament. Because of these three layers suture together to the inguinal ligament, there is increased tension. So there is increased tension over the tissue and leading to increased recurrence rate. Second is Schultes. Schultes repair. This is known as four-layered repair. Four-layered repair. Why it is known as four-layered repair? Because here we perform double breasting. Of fascia transversalis. There is modified Schultes in which we perform double breasting of internal oblique, transversus abdominis, fascia transversalis, and that is six-layered repair. So what is modified Schultes? Modified Schultes is six-layered repair. And in modified Schultes, what we perform? We perform the double breasting of internal oblique plus transversus abdominis plus fascia transversalis. If we are comparing Schultes with Bassini, relatively there is lesser tension, and if there is lesser tension, relatively there is low recurrence rate. After that, there is anterior tension-free repair. Anterior tension-free repair or anterior tension-free hernioplasty. Which one is included here? This is Lichtenstein repair. It's the Lichtenstein repair. And you know that Lichtenstein repair is the gold standard treatment for inguinal hernia. It's the gold standard treatment for inguinal hernia. So this is gold standard treatment for inguinal hernia. After that, there is laparoscopic repair. In laparoscopic repair, there is TEP and there is TAPP. TEP is totally extraperitoneal. TAPP is transabdominal peritoneal. In TEP, the working space is small. That's why it is preferred by experienced surgeons. What is the advantage here? There is decreased risk of adhesions and decreased risk of bowel injury. In TAPP, working space is large. And when there is large working space, it is preferred by beginners. But what is the disadvantage here? The disadvantage is that here there is increased risk of adhesions and there is increased risk of bowel injury. Nowadays, lots of questions are asked about various landmarks during laparoscopic hernia repair. So what are those various landmarks? Have a look. This is one of the frequently asked questions. Here you can see the first is triangle of doom. So this is triangle of doom. So what are the boundaries of triangle of doom? If you see, medially there is vas deferens. Laterally there is gonadal vessels. Superiorly or apex is by deep link. And the base or posterior border is by peritoneal edge. What are the contents? External iliac artery and external iliac vein. So if there is external iliac artery and external iliac vein, it is hidden behind the peritoneum. In this triangle, sharp dissection should not be performed, because if sharp dissection is performed, these vessels can be injured, leading to bleeding and death. So this is triangle of doom. Medially, vas deferens, laterally, gonadal vessels, apex by deep ring, and the posterior border is peritoneal edge. Content is iliac vessels. Just lateral to this is what? Triangle of pain. There is triangle of pain. This is electric hazard zone. So if you see what is this triangle of pain, can you see here? Inferolateral border is by iliopubic tract, or superiorly there is iliopubic tract. Medially there is gonadal vessels, and laterally there is peritoneum. So superiorly or superiorly there is iliopubic tract, medially there is gonadal vessels, and laterally there is peritoneum. In this region, if you can make out these yellow colored structures, all these are the nerves. So from medial to lateral, see, first is femoral nerve, after that, second is femoral branch of genitofemoral nerve, third is anterior cutaneous nerve of thigh, and fourth is lateral cutaneous nerve of thigh. That's why in this region, electrocautery should not be used, and that's why it is known as electric hazard zone. Electric hazard zone. What are the four nerves? Femoral nerve, femoral branch of genitofemoral nerve, anterior cutaneous nerve of thigh, and lateral cutaneous nerve of thigh. This is triangle of pain. Third is corona mortis or crown of death. If you see that this diagram, this is external iliac artery, and this is what? Internal iliac. The branch of internal iliac is obturator, and this inferior digastric artery is the branch of external iliac. Now, from inferior digastric artery, there is aberrant obturator artery. And this aberrant obturator artery arises from inferior digastric artery. It attaches to obturator artery, forming a vascular loop in this region. Whenever we are putting the mesh and fixing it, this aberrant obturator artery is injured, leading to bleeding and death. This is known as corona mortis or crown of death. So this is corona mortis, also known as crown of death. Corona mortis or crown of death. Here, important structure is aberrant obturator artery, which arises from inferior epigastric artery, attaches to obturator artery, arches over ligament of Cooper, injured during mesh fixation, leading to bleeding and death. These are three landmarks which are asked almost every year. After that, question is asked, what is the nerve which is most commonly injured during laparoscopic hernia repair and open hernia repair? So most commonly injured nerve during laparoscopic hernia repair is the lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh, followed by genitofemoral nerve. And during open hernia repair is the ilioinguinal nerve, followed by iliohypogastric, followed by genital branch of genitofemoral nerve. I'm repeating, ilioinguinal nerve, followed by iliohypogastric, followed by genital branch of genitofemoral nerve. So how to remember? Mnemonic is GHI in reverse sequence. So I, ilioinguinal, H, iliohypogastric, and G, genital branch of genitofemoral nerve. These are the two frequently asked questions nowadays. I told you that femoral hernia is more common in females. This is more common in females. It is more common on right side. It is bilateral in 20% cases. Having high risk of strangulation. That's why surgery should be performed as soon as possible after diagnosis. Now see the anatomical correlation. This is the femoral ring. This is the femoral canal. Lateral to this femoral ring and canal, there is femoral vein, there is femoral artery, and there is femoral nerve. Femoral vein, femoral artery, and femoral nerve. Now see the diameter of ring, 1.25 centimeter. Length of canal, 1.25 centimeter. And here there is a lymph node known as cloquet lymph node or cloquet node located in femoral canal. So if you see the diameter of ring and length, it's narrow and very rigid. And because of its narrowness and rigidity, there is increased risk of strangulation. And that's why surgery should be performed as early as possible. What are the questions related to surgery? If you see, this is the abdomen. If we give subinguinal incision, so this subinguinal is Lockwood. Inguinal is Lothisen, and suprainguinal is McEvedy. These are the approaches. Suprainguinal is McEvedy. So how you have to remember? Subinguinal, inguinal, suprainguinal, Lockwood, Lothisen, McEvedy. But be careful. The treatment of choice is Henry's procedure. For femoral hernia, the treatment of choice is Henry's procedure. Now see, what is this type of hernia? Here you can see the bulge in lumbar region of posterior abdominal wall. This is known as lumbar hernia. So in this case, there is herniation or bulge in the lumbar region of posterior abdominal wall. It can be congenital or acquired. There are two questions which are frequently asked about this lumbar hernia. Question: there is superior triangle of Greenfeld and there is inferior triangle of Pettit. What are the boundaries? So if you see this diagram, this is what? Paraspinal muscle. You can make out what? This is the 12th rib. And what you can see, this is the internal oblique. So this is the triangle known as superior triangle of Greenfeld. And if you see this triangle, this is iliac crest, this is the latissimus dorsi, and this is the external oblique. This is known as inferior triangle of Pettit. Most of the hernias are occurring via superior triangle of Greenfeld. In Bailey, it's wrongly written that it's occurring via inferior triangle of Pettit. Most of the hernias are occurring via this superior triangle of Greenfeld. So more commonly, hernias are occurring via this triangle. You have to remember the boundaries of the triangle. What's the good thing? That here the defect is very large, and that's why patient comes to us only with bulge in the lateral abdominal wall. Because of large defect, which complication is rare? Strangulation is rare. So here, the risk of strangulation is rare because of large defect. And what's the treatment? It's the Dowd's operation. Which is performed for lumbar hernia. Next is obturator hernia. It is also known as skinny, other name is skinny old lady hernia. It is also known as French hernia, skinny old lady hernia, also known as French hernia. So what are the risk factors? See, there is obturator canal. In the obturator canal, there is obturator nerve and vessels. There is fat and ligament. Whenever there is loss of fat or there is laxity of ligament, there is increased risk of this hernia. In this obturator canal, small bowel is going to enter. And when small bowel enters, it compresses the obturator nerve. Obturator nerve supplies the inner aspect of thigh. Because of compression of obturator nerve, there is pain along the inner aspect of thigh, radiating to ipsilateral knee joint. And that is known as Horship-Romberg sign. And there is absence of obturator reflex, that is known as Hannington-Giff sign. So see first, the risk factors. Risk factors are written here. Skinny old lady hernia. So first, chronic malnutrition. Second, elderly females. Third, multi-para patients. And fourth, chronic constipation. Chronic constipation. There are two questions which are asked about the clinical features. First, Horship-Romberg sign. Horship-Romberg sign. It is the pain over inner aspect of thigh. Pain over inner aspect of thigh, radiating to ipsilateral knee joint. Radiating to ipsilateral knee joint because of compression of obturator nerve. And second is Hannington-Giff sign. Hannington-Giff sign. Here, there is absence of obturator reflex. Absence of obturator reflex because of compression of the nerve. How we are going to manage? The treatment is surgical repair by posterior approach. So we perform the repair by posterior approach. Repair by posterior approach. Next is Spigelian hernia. Spigelian hernia. In this case, there is herniation after penetration of Spigelian fascia. It is also known as interparietal hernia. Interparietal hernia. Why it is known as interparietal hernia? Because contents are going to penetrate Spigelian fascia, then internal oblique, and the content is located between internal oblique and external oblique. So here, the content is located between internal oblique and external oblique. That's why it is generally not a visible swelling, neither visible nor palpable. What is Spigelian fascia? What is the location? Have a look. So if you see this diagram, you can make out that this is the lateral border of rectus, and this is what semilunar line. In between lateral border of rectus and semilunar line, there is a fascia, and this fascia is known as what? Spigelian fascia. So medially, it is bounded by lateral border of rectus, laterally by semilunar line. Now what happens? This is the arcuate line. Arcuate line. Generally, the Spigelian hernia is located at or below arcuate line. Spigelian hernia is located at or below arcuate line. In belly, it is written that mainly it is above arcuate line, but in subsystem, it is written that it is at or below arcuate line, and that is correct. So location, it is located at or below arcuate line. What is the major problem? Since it is neither visible nor palpable, there is delayed presentation. And because of this delayed presentation, there is increased risk of strangulation. Now, how you can make the diagnosis? Since it's neither visible nor palpable, diagnosis is made by either ultrasound or CT. And what's the treatment? It's the surgical repair. Next is sliding hernia. What is the sliding hernia? The other name is hernia englisade. It's also known as hernia englisade. Now, what is the problem in this case? You can make out that this is the sac. This is the sac. And here, the posterior wall of sac is formed by the viscera. Here also you can make out that this is the sac. And here, the posterior wall of sac is formed by viscera. That's why during hernia surgery, there is high risk of injury to the bowel. So, in this case, the posterior wall of sac is formed by viscera. It is more common on left side. It is more common in males. So, what is the most common content? Obviously, on left side, most common content is sigmoid. But if you're talking about right side, it is cecum. So, overall, most common content, it is sigmoid colon. And on right side, what is the most common content? It is the cecum on right side. Now, what's the problem in this case? There is increased risk of bowel injury during hernia repair. So what we perform in repair, along with sac and content, both of these are inverted back to the peritoneal cavity, and we are going to repair the defect. So, in management, invert sac plus content back to peritoneal cavity and repair the defect. So this is sliding hernia, also known as hernia englisade. After that, three definitions are asked: epigastric hernia, umbilical hernia, para-umbilical hernia. If you see this diagram, this is abdomen, this is umbilicus. Herniation directly via umbilicus is known as umbilical hernia. If herniation is occurring within 2 cm of umbilicus, this is known as para-umbilical hernia. And this is xiphoid process. From xiphoid process till 2 cm of umbilicus, any hernia is known as epigastric hernia. So umbilical hernia is centrally in the midline. Herniation directly via umbilicus, para-umbilical hernia within 2 cm of umbilicus. Epigastric hernia is herniation between xiphoid process till 2 cm of umbilicus in midline. One by one, we are going to discuss first epigastric hernia. Epigastric hernia, what's the other name? Also known as epigastric lipoma. It is also known as epigastric lipoma. It is also known as fatty hernia. Fatty hernia of linea alba. So it's very simple. Defect is there in the linea alba, and there is herniation of what? Fat. Which one? Pre-peritoneal fat. And that's why it is also known as epigastric lipoma. So it is characterized by herniation of pre-peritoneal fat via linea alba. Via defect in linea alba. Now, in 80% cases, it is just off the midline. Just off the midline. Not exactly in the midline, just off the midline. And it's multiple in 20% cases. It is multiple in 20% cases. After that, there is incarceration of preperitoneal fat. Because of this incarceration, there is referred pain to epigastrium. Referred pain to epigastrium. Because of incarceration of preperitoneal fat. And that's why, when there is referred pain to epigastrium, that's why this condition mimics what? Peptic ulcer. So it mimics peptic ulcer. Now what's the treatment? Treatment is easy because the content is preperitoneal fat. We go for excision. Excision of preperitoneal fat plus repair of defect. Plus repair of defect. And whenever the defect is more than 4 cm, we are using mesh. So we use mesh whenever the size of defect is more than 4 cm. Next is incisional hernia. Incisional hernia. It is also known as postoperative ventral wall hernia. Postoperative ventral wall hernia. So if you see these two diagrams, can you make out that there is one scar because of incision, and you can see that this is the swelling, which is covered by the skin and subcutaneous fat. Here you can make out that this is the rectus sheath, and there is rectus muscle. What happens? There is failure of fusion of this facial tissue. Because of that, there is herniation, and it is covered by skin and subcutaneous fat. So this is incisional hernia. It is caused by failure of fusion of facial tissue. Facial tissue. So in which cases there is increased risk? There is increased risk of incisional hernia. In which cases of incision? First, long, midline, vertical, lower abdominal incision. Long, midline, vertical, lower abdominal incisions. So there is increased risk of incisional hernia when there is long, midline, vertical, lower abdominal incision. There are 3 types of risk factors: surgery related, surgeon related, and patient related. See the risk factors. Risk factors. It is of 3 types. First, surgery related. Second, surgeon related. And third is patient related. In which surgeries there is increased risk? More common in emergency surgery and surgeries with wound infection. If there is wound infection, surgeon related, poor technique. There is closure under tension, and use of absorbable sutures. What about patient related? The condition which impairs wound healing, like diabetes mellitus, immunocompromised state like HIV positive, steroid intake, chronic liver disease because of impaired protein synthesis. There is jaundice and ascites. Why? Because of increased abdominal pressure. So these are the risk factors. Generally, in incisional hernia, laparoscopic repair is preferred over open repair. And what is the gold standard repair? The gold standard repair is IPOM. IPOM, and the full form is intraperitoneal onlay mesh repair. Intraperitoneal onlay mesh repair. So this is the gold standard treatment for incisional hernia. Questions are frequently asked about named hernias. One is Richter's hernia. So what is this? Richter's hernia. It is characterized by herniation of part of circumference of bowel. So what? There is herniation of part of circumference of bowel. And when this part of circumference of bowel is stuck, bowel will start doing hyperperistalsis. And because of this hyperperistalsis, there is colicky pain and the content starts moving distally. That's why these patients are having what? Colicky pain and there is diarrhea. So if there is colicky pain and diarrhea, this condition mimics acute gastroenteritis. And this leads to what? Delay in diagnosis. And because of that, there is increased risk of strangulation. Generally, it is associated with which type of hernia? Yes, femoral hernia. So it is associated with what? Femoral hernia. This is Richter's hernia, in which there is herniation of part of circumference of bowel. Sometimes the content is Meckel's. If the content is Meckel's, it is known as Litter's hernia. And if the content is appendix, what's the name? This is Ameyer's hernia. Content is appendix. This is Ameyer's hernia. What are the other named hernias? Gibbon's hernia. This is hernia plus hydrocele. That is Gibbon's. After that, Berger's hernia. This is hernia into pouch of Douglas. After that, Becklard's hernia. There is Becklard's hernia. Hernia via saphenous opening at saphenofemoral junction. Next is Ogilvie's hernia. I told you Ogilvie's syndrome. That was idiopathic colonic pseudo-obstruction. This is Ogilvie's hernia. Hernia through defect in conjoint tendon. It's hernia through defect in conjoint tendon. So hernia through defect in conjoint tendon. Ogilvie's hernia. After that, there is Stammer's hernia. This is hernia via defect in transverse mesocolon. It's hernia via defect in or hernia via transverse mesocolon after retrocolic gastrojejunostomy. So hernia via transverse mesocolon after retrocolic gastrojejunostomy. Next is Peterson hernia. Peterson hernia. Hernia behind ruling. Is hernia behind ruling after Roux-en-Y, after Roux-en-Y gastrojejunostomy. So these are the named hernia. There are three hernias which are asked in exam. These are variants of femoral hernia. So what are the named variants of femoral hernia? Variants of femoral hernia. First, Logier's hernia. Logier's hernia. This is hernia through defect in lacunar ligament. Is hernia via defect in lacunar ligament. Next is Nareth hernia. Nareth hernia. This is seen in congenital dislocation of hip. So here, the sac is located behind. Sac is located behind femoral vessels. Behind femoral vessels in congenital dislocation of hip. And third is Cloquet hernia. It's Cloquet hernia. In Cloquet hernia, here there is hernia. Sac is located in relation to fascia. So sac is located behind ectaneous fascia. Behind ectaneous fascia. So these are the named hernias which are asked frequently in exam, and these are one-liner questions which are asked frequently. After that, there are 2 to 3 questions which are asked related to abdominal wall. So these are the image-based questions. You can see here, this is omphalocele. In omphalocele, the content is covered by 2 layers, amnion and peritoneal cavity, and this is what? Gastroschisis. Gastroschisis here. The bowel is exposed and it is on right side of umbilical cord. So here you can see there is exposed bowel and which is located on the right side. So first one is omphalocele. And second is gastroschisis. In omphalocele, there is increased risk of chromosomal abnormalities, and that's why here the prognosis is poor as compared to gastroschisis. So these are the image-based questions which are frequently asked nowadays. Next question is desmoid tumor. Desmoid tumor. This tumor arises from musculo-aponeurotic structures. Musculo-aponeurotic structures. What is the location? It can be extra-abdominal. Extra-abdominal. It is extra-abdominal in 60% cases. This can be arising from abdominal wall in 25% cases, and intra-abdominal 15%. We are going to discuss the desmoid tumor arising from abdominal wall. The location is generally infra-umbilical and it arises from musculo-aponeurotic structure. There are 2 risk factors. 1, estrogen increases the risk, and history of surgical trauma. If estrogen increases the risk, it means it is more common in females. History of surgical trauma. It means any patient who had previous laparotomy or cesarean section. And third, it is associated with FAP, especially which variant is the Gardner syndrome. There is one good thing about this tumor. If you see what, there is no distant metastasis and there is no sarcomatous change. No distant metastasis, no sarcomatous change. But what is the bad thing? This tumor is going to infiltrate the surrounding muscle. And if it is going to infiltrate the surrounding muscle, during surgery we have to take sufficient margin to prevent the recurrence. What is the clinical presentation? Most common presentation is the painless lump. What is the investigation of choice for diagnosis? It's the biopsy. But be careful. Radiological investigation of choice is MRI. And how we are going to manage, since it is going to infiltrate the surrounding muscle? Treatment: wide local excision with 2 cm margin. And whenever there is recurrence, in cases of recurrence, we go for surgery plus radiotherapy. So be careful. The treatment of choice is wide local excision with 2 cm margin. When there is recurrence, then only we give radiotherapy. So this is how we treat desmoid tumor. Now we are going to discuss laparoscopy and robotics. So laparoscopy and robotics. So first question, which needle is used for creation of pneumoperitoneum? It's the Wheelis needle. Wheelis needle is used for creating pneumoperitoneum. So this is used for creating pneumoperitoneum. For creating pneumoperitoneum, what is the most commonly used gas? That is CO2. The most commonly used gas, that is CO2. What should be the flow of gas? Usually, the flow of gas is 1 liter per minute. It's 1 liter per minute. Most commonly asked question, what should be the intra-abdominal pressure maintained during laparoscopic surgeries? The intra-abdominal pressure maintained is 12 to 15 mmHg. This is frequently asked question. So intra-abdominal pressure maintained during laparoscopy is 12 to 15 mmHg. Some patients complain of shoulder pain after laparoscopy. And what's the cause of shoulder pain? It's due to CO2 retention. So shoulder pain after laparoscopic surgery, it is because of CO2 retention. And because of this CO2 retention, there is irritation of diaphragm. And because of this, there is referred pain to the shoulder via phrenic nerve. So there is referred pain via phrenic nerve to the shoulder. One more question. Whenever we create pneumoperitoneum and we insert the trocar, which layers are being penetrated by the trocar? So trocar is generally inserted at or below umbilicus, and this trocar is obviously going to penetrate first skin, after that superficial fascia, after that deep fascia, after that fascia transversalis, fascia transversalis, and after that, parietal peritoneum. Parietal peritoneum. So trocar is going to penetrate these 5 layers: skin, superficial fascia, deep fascia, fascia transversalis, and parietal peritoneum. Nowadays, questions are asked about bariatric surgery. So first see, what are the indications of bariatric surgery? Indications of bariatric surgery. First, if the patient is having BMI more than 35 kg per meter square with comorbidity. With comorbidity. And second, if the patient is having BMI more than 40 kg per meter square with or without comorbidity. This is the international guidelines. There are Asian guidelines. So in Asian guidelines, at the place of 35, it is 32.5, and at the place of 40, it is more than 37.5. So the guidelines are BMI more than 35 kg per meter square plus comorbidity, or BMI more than 40 kg per meter square with or without comorbidity. International standards. And about Asian guidelines, BMI more than 32.5 kg per meter square with comorbidity, or more than 37.5 kg per meter square with or without comorbidity. So these are the indications of bariatric surgery. Now see the types. Now here you can see, first is this vertical banded gastroplasty, and second is LAGB, known as laparoscopic adjustable gastric banding. And these two are purely restrictive. These two are purely restrictive. One question is asked, which one is safest and reversible? This LAGB. It is safest and reversible. In AIMS, one question is asked that which one is most commonly performed procedure? Roux-en-Y gastric bypass, in short, known as RYGB. This is most commonly performed. Most commonly performed. It is largely restrictive, mildly malabsorptive. So RYGB is largely restrictive, mildly malabsorptive. Now this is duodenal switch and this is biliopancreatic diversion. Both of these are largely malabsorptive and mildly restrictive. Question is asked, as maximum weight loss occurs after which procedure? It's the biliopancreatic diversion. There is maximum weight loss after the procedure. Maximum weight loss after the procedure. So these are the 5 procedures which are frequently asked in exam. After that, questions are asked about peri-operative mortality. So what's the most common cause of death? Most common cause of death in immediate post-op period. In immediate post-operative period. And the most common cause of death is peritonitis because of leakage, and maximum risk of leakage occurs from which side? Gastrojejunostomy. So it's the anastomotic leak leading to peritonitis. So it's the peritonitis caused by anastomotic leak, and mainly at which site? At gastrojejunostomy. Second question, what's the most common cause of death within 30 days of surgery? Most common cause of death within 30 days, and that is pulmonary embolism because of DVT. Because obesity is a risk factor for DVT. So it's the pulmonary embolism, followed by cardiac complications, followed by anastomotic leak. So 2 questions, you have to read the question carefully. Most common cause of death in immediate post-operative period, it is peritonitis caused by anastomotic leak, and within 30 days, it is pulmonary embolism. Now what is this surgery? This is notes. What is the full form? Natural orifice transluminal endoscopic surgery. We are using natural orifice like oral cavity, like vagina, like rectum for performing surgery. Here you can see, with the help of endoscope, I'm performing the cholecystectomy. So the full form is natural orifice transluminal endoscopic surgery. Natural orifice transluminal endoscopic surgery. So the natural routes or natural orifices which are used, that is oral cavity, rectum, and vagina. These are commonly used natural orifices. What are the surgeries which were successfully performed? We performed cholecystectomy and appendectomy. Cholecystectomy and appendectomy. I discussed one type of nodes in achalasia cardia, and that is POEM. What is POEM? It's the per oral endoscopic myotomy. It's a type of nodes, and this is performed for achalasia cardia. Now you can see, this is Da Vinci robot, and this is used for robotic surgery. Da Vinci robot used for robotic surgery. It is based on master-slave principle. Generally, this robotic surgery is used at the places where fine surgery is being performed and the space is very limited. So generally, this robotic surgery is performed nowadays for prostatectomy, performed for gynecological operations, and cardiac valve repairs. So these are the latest questions related to laparoscopic and bariatric surgery. Now we are going to discuss transplantation. So first of all, history of transplantation. These are the frequently asked one-liner questions. So who performed first liver transplantation? Who performed first renal transplantation? So first renal transplantation was performed by Murray, and he performed it in identical twins. So it was performed by Murray. You have to remember, he performed this in identical twins. Second question, who performed first liver transplantation? First liver transplantation was performed by Stargell. Third question, who performed first pancreas? First pancreas transplantation. It was performed by Kelly and Lilhay. Kelly and Lilhay, who performed first islet cell. First islet cell transplantation. In islet cell transplantation, islet cells are injected into portal vein, and this was performed by Sutherland. This was performed by Sutherland, who performed first heart transplantation, and this was performed by Christian Bernard, who performed first lung transplantation. It was performed by Fritz de Rome, and who performed first heart plus lung transplantation. Two surgeons were there, Reeds plus Shumway, and who performed first be careful, first successful small bowel transplantation. First successful small bowel transplantation or intestinal transplantation. It was performed by Dents and colleagues. So this is the history of transplantation. Lots of one-liner questions are asked. After that, questions are asked, what's the most common malignancy seen in transplant recipient? It's the skin cancer. Which type? Squamous cell carcinoma. So most common malignancy seen in transplant recipients, it's skin cancer. This question was asked minimum 5 to 6 times. Which type? Squamous cell carcinoma. So because of immunosuppressive agents, there are two problems. One, increased risk of infections, and second, increased risk of malignancy. Which one is most common malignancy? Skin cancer, that is squamous cell carcinoma. In the latest exam, Maastricht classification was asked. So what is this Maastricht classification? This Maastricht classification is for DCD donors, that is donation after circulatory death. Donation after circulatory death, in short known as DCD donors. So there are 5 categories. Now see what are the categories of Maastricht classification. Category 1, 2, 3, 4, and 5. Now see what is the description. Category 1, here the donor is dead. So dead on arrival at hospital. This is category 1. Category 2, resuscitation attempted without success. Resuscitation attempted without success. Category 3, awaiting cardiac arrest. Awaiting cardiac arrest after withdrawal of support. After withdrawal of support. This was the question in the latest exam, that most DCD donors belong to which category? Most DCD donors belong to category 3. So most DCD donors belong to category 3, that is awaiting cardiac arrest after withdrawal of support. What is category 4? Category 4 is cardiac arrest while brain dead. Cardiac arrest while brain dead. And category 5, cardiac arrest and unsuccessful resuscitation in hospital. Unsuccessful resuscitation in hospital. So how to remember these categories? The mnemonic is Dracula. Now, dead on arrival at hospital, resuscitation attempted without success. A, awaiting cardiac arrest after withdrawal of support. C, cardiac arrest while brain dead, and cardiac arrest with unsuccessful resuscitation in the hospital. Unsuccessful resuscitation in the hospital. So these are the 5 categories. Most DCD donors belong to category 3. In transplantation, lots and lots of questions are asked about indications of transplantation. Which one? Especially the liver transplantation. Indications of liver transplantation. So question, what's the most common indication? Most common indication of liver transplantation. This is HCV-induced cirrhosis. HCV-induced cirrhosis. Followed by alcoholic liver disease. So question is asked, what is the second most common indication of liver transplantation? That is alcoholic liver disease. So question, second most common indication of liver transplantation, that is alcoholic liver disease. This question was asked in the latest exam. Most common indication of pediatric liver transplantation. Most common indication of pediatric liver transplantation, and that is biliary atresia. Next, most common metabolic disorder requiring liver transplantation. Most common metabolic disorder. So most common metabolic disorder requiring liver transplantation, and that is alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. Next, most common indication of liver transplantation following acute hepatic failure. Most common indication of liver transplantation following acute hepatic failure, and that is acetaminophen toxicity. Acetaminophen toxicity. So these are the one-liner questions asked about indications. Here was one question related to the sequence of anastomosis in liver transplantation. Have a look. So see the sequence of anastomosis in liver transplantation. This is first, that is suprahepatic. First is suprahepatic IVC. This is second, that is infrahepatic IVC. This is third, that is portal vein. This is fourth, and that is hepatic artery. And this is fifth, that is bile duct. So this is the sequence of anastomosis. First is suprahepatic iris, second is infrahepatic iris, third is portal vein, fourth is hepatic artery, fifth is bile duct. How to remember? There is a mnemonic. Mnemonic is SIF-B. Sequence of anastomosis in liver transplantation. SIF-B. Suprahepatic iris, infrahepatic iris, portal vein, hepatic artery, bile duct. After that, question is asked, in bile duct anastomosis, which anastomosis is preferred? It is choledochocholedochostomy or choledochojejunostomy. So in bile duct anastomosis, it's the choledochocholedochostomy which is preferred over choledochojejunostomy. So CDCD, choledochocholedochostomy is preferred over choledochojejunostomy. Choledochojejunostomy is performed in the cases where it's difficult to perform choledochocholedochostomy. So what is the indication? Indications of choledochojejunostomy. First, there is diseased extrahepatic bile duct. Diseased extrahepatic bile duct of recipient, like primary sclerosing cholangitis where extrahepatic bile duct is diseased and it's an indication for liver transplantation. Second, there is significant recipient donor duct size mismatch. Recipient and donor duct size mismatch. Why? Because it's difficult to perform the anastomosis. These are the two indications of choledochojejunostomy in liver transplantation. Nowadays, questions are also asked about sequence of anastomosis in heart transplantation. So what is the sequence of anastomosis in heart transplantation? Now the sequence of anastomosis in heart transplantation, first is left atrial anastomosis. After that, right atrial anastomosis. After that, pulmonary artery anastomosis. And last is aortic anastomosis. So first left atrial, followed by right atrial, followed by pulmonary artery, and followed by aortic anastomosis. So how to remember? The mnemonic is LARA, PARA. LARA, PARA. LA, that is left atrial. RA, that is right atrial. P, that is pulmonary artery. AR, that is aortic anastomosis. So LARA, PARA, left atrial, followed by right atrial, followed by pulmonary artery, followed by aortic anastomosis. Sequence of anastomosis in heart transplantation. Now see the sequence of anastomosis in lung transplantation. So here, the first is pulmonary vein anastomosis, followed by bronchial anastomosis, followed by pulmonary artery anastomosis. So how to remember? The mnemonic is PV by BA, PA. PV. First is pulmonary vein, second is BA, bronchial anastomosis, and third is pulmonary artery. So PV by BA, PA. These are the questions which are frequently asked about the transplantation. Now we are going to discuss the nutrition. First, the methods of adjuvant nutritional support. Methods of adjuvant nutritional support. First is enteral nutrition, and second is total parenteral nutrition. What is the meaning of enteral nutrition? It means the delivery of nutrients into GIT. So in enteral nutrition, there is delivery of nutrients into GIT. So what are the routes for enteral nutrition? The routes for enteral nutrition are feeding, gastrostomy, feeding, jejunostomy, and if you are not going for gastrostomy or jejunostomy, we can insert the nasogastric tube or nasojejunal tube. So first, nasogastric tube or nasojejunal tube. Now which one is preferred? Nasojejunal tube is preferred because of decreased risk of aspiration. So it's the nasojejunal tube which is preferred because of decreased risk of aspiration. Second is gastrostomy, and third is jejunostomy. In gastrostomy and jejunostomy, obviously, jejunostomy is preferred because of same reason. What? There is decreased risk of aspiration. Jejunostomy is preferred because of decreased risk of aspiration. Questions are asked about gastrostomy. That what are the various techniques used for gastrostomy? The various techniques used are Stam, Witzel, and Janeway. Stam, Witzel, and Janeway. These are not used commonly. Nowadays, we are using PIG, that is percutaneous endoscopic gastrostomy. This one is commonly used for gastrostomy nowadays, percutaneous endoscopic gastrostomy. Now this jejunostomy, this is preferred because of decreased risk of aspiration, and it is specially useful in severe pancreatitis. Specially useful in severe pancreatitis. After that, total parenteral nutrition. So what are the indications of enteral nutrition? So question, indications of enteral nutrition. So first is protein energy malnutrition with inadequate oral intake. With inadequate oral intake. So protein energy malnutrition with inadequate oral intake. Second is dysphagia except for fluids. Dysphagia except for fluids. Third, major trauma or surgery. Major trauma or surgery. Fourth, inflammatory bowel disease. Fourth, distal low output enterocutaneous fistula. What is the definition of low output enterocutaneous fistula? Whenever the output is less than 200 ml per day. So output less than 200 ml per day. And fifth, to enhance adaptation after enterectomy. So these are the indications of enteral nutrition. Now we are going to discuss total parenteral nutrition. So what is this total parenteral nutrition? It's the provision of all nutrients via IV route, intravenous route. So provision of all the nutrients via IV route. So which IV route is preferred? What are the various access sites? The preferred vascular access site is subclavian vein. After that, internal jugular vein. After that, femoral vein. So preferred venous access site is subclavian vein, followed by internal jugular vein, followed by femoral vein. This question is frequently asked in exam. asked frequently. So another question, what is the most common complication after central venous catheterization? So most common complication of central venous catheterization, because catheter is there, so there is catheter related sepsis. Is the catheter related sepsis. Catheter related sepsis. Second question, what is the most dangerous complication following CVC, central venous catheterization? So most dangerous complication following central venous catheterization, and that is pneumothorax. So these are frequently asked one-liner questions related to TPN. What are the indications of total parenteral nutrition? Have a look. The indications of total parenteral nutrition. First, gastrointestinal cutaneous fistula. Second, renal failure. Third, we discussed short bowel syndrome. There is malabsorption, short bowel syndrome, acute burns, hepatic failure, and Crohn's disease, and anorexia nervosa. So these are the indications of total parenteral nutrition. Questions are asked about TPN formulations. So there are two commonly used TPN formulations, one with lipids and one without lipids. So see the TPN formulations. There is solution with lipids and there is solution without lipids. If apart from dextrose amino acid there is lipid, that is 3 in 1, and there is dextrose amino acid but there is no lipid, that is 2 in 1. So first is 3 in 1 and the second is 2 in 1. So see, in solution with lipids, which is also known as 3 in 1 formula, here we are using what? Dextrose, we are using amino acid, and we are using lipids.